Good afternoon, and today's lecture is on the assessment of renal function, and I am Nam Tran. I'm one of the assistant adjunct professors through the Department of Pathology and Laboratory Medicine at the University of California, Davis. Our learning objectives are as follows. First, we're going to learn the clinical importance of assessing renal function. Number 2, identify current and future biomarkers for assessing renal function. Next, we're going to describe the analytical principles of Amperometric and immunochemistry-based renal function tests, and then describe basic definitions for acute kidney injury or AKI, chronic kidney disease or CKD, and cardiorenal syndrome, and lastly, identify risks for AKI and how renal function testing could be applied in critically ill populations. So to give a little bit of background, there are two types of kidney failure or kidney injury. The first, shown here on the left, is acute, and on the right, chronic. Acute kidney injury is typically kidney injury or failure that develops within hours or days and includes the chance of kidney function recovering. On the other hand, chronic is the result of failure that develops over years and it has typically an irreversible endpoint. In particular, the incidence of acute kidney injury, which includes acute kidney failure, has increased from 60 to 500 events per 100,000 patients over the last decade. In contrast, the prevalence of chronic kidney disease or CKD in adults within the United States was estimated to be about 11%, so that's about 19.2 million people. Currently, the monitoring of serum creatinine and urine output are common methods for assessing renal function, especially for determining AKI severity in the critically ill and managing CKD. As you can imagine, the use of serum creatinine and urine output are done mainly because it is a very convenient test. We also see new biomarkers for determining renal function, and they are now slowly becoming more available within the laboratory setting. And these tests and new biomarkers could be used to complement creatinine testing when managing AKI and CKD. We're now going to first focus on acute kidney injury. So, the typical causes of acute kidney injury include the main mechanisms of acute kidney injury typically are prerenal, intrinsic, or postrenal. Prerenal, for example, can be due to systemic hypotension, heart failure, hypovolemia, trauma, and induced by drugs. These examples shown here illustrate that the prerenal mechanisms typically occur at the blood vessels that feed the actual kidney. For intrinsic acute kidney injury, you see that drug and toxin-induced mechanisms are also prevalent, where drugs cause damage directly to the nephrons. Infection as well as autoimmune diseases can also cause intrinsic damage. And lastly, postrenal mechanisms typically are due to kidney stones and other mechanical blockages of the ureter and so forth, which prevent urine from being removed from the body. And another example would be benign prostatic hyperplasia and, of course, prostate cancer. How we determine the actual degree of acute kidney injury is based on two methods. First, here being the RIFLE criteria. This was actually proposed around 2004 or so. And RIFLE is an acronym standing for risk, injury, failure, loss, and end-stage renal disease. And of course, as you go down the RIFLE criteria from R to E, the more severe the acute kidney injury is. The RIFLE criteria can be measured based on glomerular filtration rate or estimated creatinine clearance, or by urine output. Here, this figure shows how GFR criteria can be used, where decreases in GFR, depending on to what degree, will stratify the patient into each of these RIFLE criteria. Alternately, urine output, as urine output decreases over a certain period of time, and ultimately to no urine output, this also is a method for determining how severe AKI is. The second method for determining the severity of acute kidney injury is the Aiken criteria, or AKIN. And the Aiken criteria was developed to be analogous to how we stage cancer. Again, as with the RIFLE criteria, the Aiken criteria is determined based on serum creatinine clearance, or just serum creatinine levels, as well as urine output. And you can see here again that as serum creatinine levels increase, so does the degree of Aiken staging from 1 to 3, with 3 being the most severe. And the same goes for urine output. As urine output decreases, so does the increase in Aiken criteria and staging that comes with it in terms of severity. Now we're going to switch gears and talk about chronic kidney disease, or CKD. So just a little bit of a refresher. Of course, acute kidney injury occurs very quickly, and there's a potential for renal function to recover, and due to pretty much acute reasons, including trauma, acute intoxications, organ failure, and infections. Now, shown here on the right, you can see that chronic kidney failure or chronic kidney disease is a long process that occurs over the course of years and is typically irreversible. Chronic kidney disease is typically due to high blood pressure, diabetes, chronic bacterial inflammation of the kidneys, cystic kidney disease, and various autoimmune disorders. Just like how we can stratify the severity of kidney disease in terms of acute kidney injury with the Rifle and Aiken criteria, and we also see here that chronic kidney disease could also be staged, with again here 1 being the least severe and 5 being the most severe, and this of course stage 5 CKD would be kidney failure, and this is based on the Kidney Disease Outcome Quality Initiative published in 2003, shown below. And again, you can see it's based on typical measures of renal function, in this case glomerular filtration rate. Now to change gears a little bit, we're going to talk about cardiorenal syndrome, and this concept has been around for quite some time. By definition, cardiorenal syndrome, or CRS, is heart and kidney dysfunction where the primary organ, either the heart or kidney, failing can precipitate failure of the other. So it illustrates the linkage between these two important organs. CRS is further subtyped into 5 different categories. Type 1, worsening heart function leading to acute kidney injury. Type 2, chronic heart failure, or CHF, leading to chronic kidney disease. Type 3, acute kidney injury leading to acute cardiac dysfunction. Type 4, primary CKD leading to chronic heart failure. And lastly, Type 5, combined cardiorenal dysfunction due to acute or chronic disorders. This slide summarizes visually CRS type 1. Again, this is worsening heart function leading to acute kidney injury, where acute heart diseases due to procedures, acute decompensation, ischemic injury, coronary angiography, cardiac surgery, and so forth leads to a decrease in cardiac output, which of course subsequently leads to decreased perfusion, increased venous pressure, which of course affects the kidney. Other mechanisms can also play a role. Here you can see, as we move down the list of items, exogenous factors such as contrast media, ACE inhibitors, diuretics, and all this ties together, which can exacerbate the renal dysfunction, and this leads to reduced oxygen delivery to the nephrons and the various other tissues within the kidney, decreased GFR, and altered function in the actual system, leading to release of biomarkers shown here, such as KIM1 or kidney injury marker 1, cystatin C, NGAL, and creatinine. And we'll talk more about these biomarkers shortly. And there's of course a variety of other feedback loops and so forth due to humorally mediated damage and other factors, as you can see. For CRS type 2, this is chronic heart failure leading to CKD. And we can see here that chronic heart disease, due to a variety of factors such as genetic risk factors, acquired factors that lead to low cardiac output, can increase susceptibility of the kidney to a variety of insults. This leads to chronic hyperperfusion if the heart disease is not addressed, and leads to apoptosis of the renal parenchyma. Low cardiac output can also contribute to subclinical inflammation, endothelial dysfunction, and also due to accelerated atherosclerosis, and this is a little bit more severe, leading to insult and initiation of actual kidney damage. Over a longer period of time, this damage can lead to sclerosis and fibrosis of the kidney. Now, if the heart, of course, leads to a series of other events, including chronic hypoperfusion, increased renal vascular resistance, increased venous pressure, or potentially any embolism that may occur, this can really push the kidneys towards progression of chronic kidney disease. And of course, the sequelae that can occur from This renal dysfunction also feeds back to the heart, which further exacerbates the heart pathology. This can be due to anemia, sodium and water retention, uremic solute retention, calcium and phosphate abnormalities, hypertension, anemia, and the list goes on. This next slide shows CRS type 3, acute kidney injury leading to acute cardiac dysfunction. Here we have acute kidney injury due to glomerular diseases, interstitial diseases, acute tubular necrosis, acute pyelonephritis, acute urinary obstruction, and so on. And this leads to decreased GFR, water and sodium retention, volume expansion, etc., and of course ultimately leads to hypertension. The hypertension then potentially leads to acute heart dysfunction, secondary to acute decompensation, acute heart failure, ischemic insult, arrhythmias, and ultimately decreased cardiac output. And this, of course, will lead to the release of various cardiac injury markers, including the troponins, myoglobin, myeloperoxidase, and B-type natriuretic peptide. Other mechanisms can also play a role, as you can see here, with electrolyte acid-base disturbances as well as coagulation disturbances with CRS type 3. CRS type 4, we see primary chronic kidney disease leading to chronic heart failure. And you can see here on the left where CKD stage 1 through 2, which is due to glomerular and interstitial damage, then progressing to CKD stage 3 and 4, and then leading to sclerosis and fibrosis of the kidney, and ultimately ending at CKD stage 5 requiring dialysis. All these mechanisms can be precipitated by various comorbidities, including smoking, obesity, hypertension, dyslipidemia, and so on, and all these feed into cardiac dysfunction. This can lead to cardiac remodeling, neurohormonal abnormalities, increased ischemic risk, left ventricular hypertrophy, left diastolic dysfunction, and so on. And biomarkers for the heart will also be prevalent, including, of course, the cardiac troponins, natriuretic peptides, acute phase protein, C-reactive protein, and so forth. And lastly, we have CRS type 5, which is actually the most interesting one, at least from my perspective, due to it catching a variety of acute care setting conditions. And in this case, we have combined cardiorenal dysfunction due to acute or chronic disorders. And as an example, this can be due to systemic diseases, diabetes, amyloidosis, vasculitis, and of course sepsis. And of course, as a reminder for the audience, sepsis is still the #1 cause of death in non-coronary intensive care units. And of course, one of the first organs to have issues in the ICU setting, secondary to sepsis, is of course the kidney, and as well as the heart. And you can see here heart failure can contribute to this, as well as renal insufficiency leading to this. And this leads to altered homeostasis, including hypoxia, oxidative stress, toxemia, and so forth, and various other exogenous factors such as the bacterial lipopolysaccharide, or LPS, and endotoxin can lead to organ dysfunction that can impact both the cardiac and renal dysfunction, and these two organs can feed back upon each other, leading to further cardiorenal syndrome. Well, given cardiorenal syndrome, acute kidney injury, and CKD, how do we actually measure the extent of renal dysfunction? And so here we're going to start talking about renal function testing. And of course, we've alluded to some of the methods, including creatinine testing, urine output, and estimation of glomerular filtration rate. So of course, the assessment of renal function is usually focused around filtration, and filtration is typically a good measure of how well the kidney is being perfused. And as a little refresher, of course, we have a blood vessel, the afferent arteriole, feeding the glomerulus, and the blood leaves with the efferent arteriole. And of course, this is ultimately based on the filtration, is based on the Starling hypothesis, as shown here, where the pressure-based filtration is what pushes the fluids across. And of course, we have a K sub F coefficient, the actual filtration coefficient, which identifies how permeable the actual membrane is. And of course, the membrane in this case is the glomerular capillaries and the Bowman's capsule. Ultimately, to measure glomerular filtration rate, or GFR, we have to be able to measure the urine concentration. So in this case, some kind of molecule that's in the urine that we can measure that's neither reabsorbed or secreted, times the amount of urine that flows by, all divided by the concentration of this biomarker. And a good classic biomarker that has been used at the bench side typically is inulin, INULIN, not insulin. So inulin is used because it is neither secreted or reabsorbed by the kidney. Of course, we can't be giving inulin all the time, and we have to find an endogenous biomarker that can be used as a surrogate. And in this case, we have creatinine. As a little refresher here, creatinine is a product of a molecule inside your muscles. And we see here that creatine can be converted by creatine kinase to creatine, and then that can convert to creatinine. And creatine can also directly be converted to creatinine. And ultimately, creatinine can be filtered by the kidneys and is typically not reabsorbed. However, under various conditions, this can occur. The main issue is, however, that creatinine clearance is often an overestimation of renal filtration due to actual secretion in the proximal tubules. So it is okay to use in most settings, but under especially critically ill patient settings, this can cause issues where creatinine clearance could be an overestimation. Some measurements of creatinine could also be susceptible to nonspecific chromogens, and ultimately, from a laboratory standpoint, this can lead to inaccuracy and precision of assessment of renal function. Now we move on to how we can determine creatinine clearance, which is of course an estimation of how well the kidneys are filtering. And one method is based on the Cockcroft-Gault equation, and this equation estimates creatinine clearance. You can see here that it takes an age, patient age, their mass in kilograms, if they're female, and all divided by the amount of serum creatinine that you measured using various analytical principles. Alternately, you have the MDRD equation shown here, the modification of diet in renal diseases, and this is used for estimation of glomerular filtration rate, or EGFR, and it does a similar method of analysis that takes into account the serum creatinine, it takes into account age, as well as if you're female or not, and if you are African American. And so the reason why these two equations look for gender, in this case, if you're a female, of course, muscle mass will be different between genders on average. And in terms of the MDRD, African Americans typically have larger muscle mass. So, of course, as you recall, creatinine is a product from compounds within the muscle. So creatine, so if you have more muscle, you may have more of creatinine. And this equation is used to account for that. However, the equations that you just saw aren't necessarily accurate, and as new technologies come about, especially to account for various interferences of creatinine testing, and in particular the use of isotope dilution mass spectrometry, so IDMS, has been used to calibrate creatinine testing, there has to be better methods for measuring renal filtration. In this case, the CKD epi equation is used. It pretty much uses the same variables, which include serum creatinine as well as age, and of course if you're female or not, if you're African American or not, and there are improved constants in this case for male versus female and so forth to actually improve the accuracy of renal filtration estimation based on serum creatinine. This next slide shows another biomarker, blood urea nitrogen, or BUN. And BUN represents the amount of urea nitrogen found in blood. BUN is also filtered by the kidneys, however, their levels are also affected by protein degradation, hydration status, and liver function. BUN reabsorption and secretion in the kidney also changes relative to disease conditions, so it's not really that great. However, the use of the BUN creatinine ratio may be useful in differentiating the mechanisms of AKI. So as an example, the BUN creatinine ratio, as values are greater than 20, they are indicative of or suggestive of pre-renal mechanisms of AKI. If the ratio is between 10 to 20, then it is potentially post-renal, and if the values are less than 10, then it may be intrinsic mechanisms of AKI. Well, now we move on how we actually measure these biomarkers such as creatinine, blood urea nitrogen, and so forth. And this really revolves around the use of amperometry or amperometric biosensors. Leland Clark was the guy that pretty much invented this type of biosensor. It really started out back in 1954, where he invented the oxygen electrode in his closet shelf in his home. In 1962, so about 8 years later, he ultimately reversed the polarity of the platinum electrode on the actual sensor and included glucose oxidase, an enzyme which led to us being able to measure glucose. Of course, glucose has now become a very important field where the amount of money that has been pumped into this market has now potentially exceeded $11 billion. And this is, of course, an estimate in 2016, but we are surely moving in that direction. Ultimately, amperometry, as the name implies, measures amps. And amps is the unit of measurement for current. So we are measuring the movement of charge through a actual potential. And you can see here, this is a general schematic of an amperometric enzyme-based biosensor, and this can allow us to measure various biomarkers, not just limited to glucose, but we can measure BUN, creatinine, as well as lactate. And ultimately, the substrate, so it could be creatinine as an example, reacts with an enzyme specifically, which leads to a product, but also electrochemical reaction that generates electrons, and these electrons are ultimately measured, and that's your response, and can be quantified to tell the user how much creatinine or any other biomarker that. A typical creatinine biosensor requires the use of 3 enzymes. You can see here that the first enzyme, creatinine imidahydrolase, followed by the next enzyme, creatinine imidodinohydrolase, and lastly, sarcosine oxidase, catalyze a series of reactions that ultimately generate electrons through the dissociation of the end product, as shown here in the bottom right, hydrogen peroxide. So you start off with creatinine, which with water is converted to creatine via creatinine imidahydrolase. The creatine with water then is converted to sarcosine and urea via creatinine imidodinohydrolase through that catalytic reaction, and then the sarcosine and urea with water as well as oxygen, diatomic oxygen, is converted by sarcosine oxidase to glycine, formaldehyde, and hydrogen peroxide. And of course, classically, hydrogen peroxide quickly dissociate, yielding water and oxygen and electrons. And these electrons are measured, and one can see that the amount of creatinine reacted in this reaction is stoichiometrically related to the amount of current that is generated by the system, and that's how we measure creatinine. Here are some creatinine biosensor designs. You should see here on the left, which is typically the design of a creatinine sensor for a mainframe system in a clinical laboratory. And you can see that there's an outer membrane, an enzyme layer, an inner membrane, which ultimately then leads to the electrodes that are in the sensor. The more common technologies which are used at the point of care, you can see here on the right that much of the sensor components have been miniaturized and flattened out, which allows these devices to use strips, just like an actual glucose meter to measure creatinine. Here is an example of a test strip based point of care creatinine device, and this is a device from Nova Biomedical, and you can see here the test strip, which shown here in exploded view, has 4 layers, which the first layer is a gold layer, which of course is the electrodes. The electrodes, there are 4 actual electrodes that allow this strip to measure creatinine, but also correct for various interferences, including hematocrit and ascorbic acid, which have been known to interfere with these electrochemical reactions. And the sample, which is 1.2 microliters in volume for blood, can be drawn in through capillary action and measured quite quickly. Of course, we're not going to be complete without various other types of tests. In addition to creatinine and BUN and so forth, we have, of course, urine dipsticks, which are able to test for a variety of biomarkers, including pH, specific gravity, and so forth. But we also have microalbumin osmolality tests and so forth that allow you to assess renal function. Well, now we're going to move on to other biomarkers of kidney injury. Creatinine and so forth are useful, but they're not necessarily the only ones that are out there that can evaluate how well kidneys work. And there is now a lot of effort into coming up with biomarkers for kidney injury. This slide shows a variety of compounds that can lead to kidney injury. In this case, these are drugs. So the proximal tubules are typical sites for damage of various types of antimicrobials, such as vancomycin, gentamicin, neomycin, tobramycin, amikacin. Gentamicin, tobra, and amicase, of course, are your famous aminoglycosides, but also various chemotherapeutic agents, including cisplatin and so forth. The glomerulus is another target for drug-related nephrotoxicity, and you can see pyrimycin and a variety of gold even are also toxins for this tissue. The distal tubules are also sensitive to other compounds, including amphotericin B, which is an antifungal. The collecting duct as well. Acyclovir also affects this area. That's an antiviral, antiherpetic drug. And analgesics, chronic use of analgesics can lead to damage of the loop of Henle. Very interestingly, you can see that there are many biomarkers of acute kidney injury and as well as chronic kidney injury. So you can see here the proximal tubules are related to a variety of biomarkers after injuries, such as KIM1. Again, KIM1 is kidney injury marker 1, cystatin C, IL-18 or interleukin-18, albumin, and the list goes on. And you see the glomerulus also has a variety of compounds, including cystatin C, but urine cystatin C, albumin. The distal tubules have a few, collecting duct, and the loop of Henle. But the one I want to really focus on next is NGAL, shown here in the distal tubule and the proximal tubule. NGAL, or neutrophil gelatinase associated lipocalin, is a 25 kilodalton member of the lipocalin family, encoded by the LCN2 gene. And a variety of gene expression studies showed that the LCN2 gene is highly expressed following ischemic and nephrotoxic injury. This compound, however, was first characterized in neutrophils, hence the name. It was observed binding bacterial siderophores during the innate immune response, and it is strongly upregulated during inflammation mediated by IL-1 rather than tumor necrosis factor alpha. Well, having seen the LCN2 gene being highly expressed after renal injury, various researchers focused on the use of NGAL as a biomarker for acute kidney injury. And what was found was NGAL was massively released from the renal tubular cells following injury, but NGAL is also freely filtered by the glomerulus. So when renal function decreases, of course, the glomerular filtration rate is also reduced, leading to an increase in serum NGAL levels. And when coupled to renal tubular cells expressing NGAL, you'll have a significant increase in urine NGAL. And NGAL is also reabsorbed, which thereby increases substantially the amount of blood NGAL systemically during this acute kidney injury event. The clinical performance of NGAL is quite good. I do want to emphasize this is just an example, and there's many other biomarkers out there, as you saw, including cystatin C and KIM1, that also perform quite well. But for the sake of time, today we're going to focus on NGAL. And typically the normal NGAL range is between 40 to 100 nanograms per milliliter. Plasma NGAL has been shown in one study to be highly predictive of acute kidney injury in the ICU setting. Area under the receiver operator characteristics curve was 0.92, which is actually quite good. And if you recall, the larger the area in the curve under our ROC curve, the better the performance. In another study, patients with a mean NGAL of 342 nanograms per ml actually developed AKI within 48 hours, and many of these patients were required actual renal replacement therapy, and this is actually quite interesting. And then another study, when you couple NGAL with B-type natriuretic peptide testing, or BNP testing, it actually improves the sensitivity, so the clinical sensitivity for detecting NGAL with a sensitivity of 94%, specificity of 61% for BNP levels of greater than 267 picograms per ml and NGAL levels of greater than 231 nanograms per ml as cutoffs. So how does NGAL and all these other biomarkers do in an actual clinical setting? Well, first we have to be able to measure NGAL, and as well as BNP if we want to use those two cutoffs that was described by the previous paper. And one of the first assays to actually incorporate both BNP and NGAL is shown here. This is the triage meter by Allaire, and this is a immunoassay-based test. The range of detection for BNP is 5 to 5,000 picograms per ml, and NGAL ranges from 15 to 1,300 nanograms per ml. The actual turnaround time is 15 to 20 minutes. Sample volume is 240 microliters of anticoagulated whole blood, anticoagulated by EDTA. So in short, you dose this test card with blood, insert it into the instrument, and after some amount of time, the results come out. So this next slide shows the actual test card up close. You can see where the sampling well sits, and then there's an actual detection window. If I were to show you a side view of the test strip as shown here at the bottom, you can see that once the blood is dosed, the dosing area contains free labeled antibodies for BNP and NGAL, and these antibodies can be labeled by an enzyme or a fluorophore, and downstream distally from this actual sample well are a variety of fixed antibodies, and these antibodies are also specific for NGAL and BNP. So here we can see that the pink area, that's the blood, and the BNP and the NGAL shown here in the text now sit and bind to the actual antibodies, the free antibodies. The free antibodies are then moved up along the actual sensor via capillary action and eventually bind to the antibodies, the fixed antibodies. And lastly, these antibodies are bound to the fixed antibodies and are now in the actual detection window. Any excess freely bound antibodies that are fluorescent labeled move off outside the detection window. A beam of light, could be a laser and so forth, illuminates and excites these fluorophores, and then the fluorescence is detected by an optical detector. Of course, many different types of similar formats can be used. Of course, like I said, it could involve enzymes in addition to fluorophores to help detection of these biomarkers. And this type of assay format is also used for a variety of other biomarkers, including cardiac biomarkers, as used previously. So now that we understand how we test these things and how it performs, we now try to figure out how it impacts patient care. So in this case, this next series of slides is the clinical application of biomarker testing in the effort to predict acute kidney injury during burn resuscitation. This field of burn surgery is actually quite new, and modern burn care came about from 1942, and this is a beautiful club out in Boston, Massachusetts called the Coconut Grove Club. The problem was in 1942 there was a massive fire, and what occurred was all these people that were in this structure were trapped inside because there were not that many exits, and the fire code for these facilities during the 1940s were not up to not modernized compared to what we have now. So a variety of people were actually burned, and the local hospital was effectively inundated, and that of course was Massachusetts General Hospital, part of Harvard School of Medicine. And one of the burn patients was a sailor who was on leave from being deployed during World War II. If you recall, World War II was happening during this time, and this patient was severely burned, 50 to 80% burns, and during that time a person of that burn size was pretty much considered a goner. And so the physicians at Mass General decided to assign a medical student to keep an eye on this patient and keep him comfortable, and those were his orders. And through the course of the evening, after being told that he probably would not survive, the med student obliged and tried to keep the patient comfortable, and the patient kept asking for fluids. So the med student obliged and gave more fluids, something to drink over the course of the evening, and kept giving this guy something to drink, and lo and behold, the patient survived. Well, the med student went off and became a physician, and no one really heard of him after that, but a surgery resident, Dr. Stanley Levinson, realized that there was something interesting in regards to this patient drinking lots of water and relating it to actual survival. And this was ultimately not realized until 1968 at Parkland Medical Center, where it was pretty much determined if you give a patient a lot of fluids after severe burn injury, they will do better. And this was ultimately protocolized by Dr. Charlie Baxter, and this was ultimately called the Parkland formula in 1968. And it's defined as 4 mLs of lactated ringers for every percent body surface area burned per kilogram body weight, and half of this amount is given over the first 8 hours, with the remainder given in the last 16 hours. In reality, this is a starting amount, and the fluid rate is titrated to maintain urine output between 30 to 60 mLs per hour. This is typically for an adult, and until maintenance rate is achieved. So that's shown here as an example. You have a 100 kilogram patient with 50% burn. This person would need a total of 20,000 mLs or 20 liters of fluids over the first 24 hours, with half of that given the first 8 hours. So that's at a starting rate of 1,250 mLs per hour. More severe burns, the more fluids they get, and we've seen fluids as high as 3,000 mLs per hour. And of course, that also comes with a variety of complications. These complications, which are ultimately under inadequate resuscitation, can be classified in 2 groups. The first being under resuscitation. You did not give enough fluids. And you can see that acute under-resuscitation can lead to hypoperfusion, organ dysfunction, including AKI, and eventually death. Long-term consequences are also quite extreme, which includes increased risk for sepsis, and this is believed to be due to bacterial translocation due to increased permeability of the mucosal membrane, secondary to actual reduction of blood flow to the gut. On the other hand, over-resuscitation is not a good thing either, and so you can't just pump this person full of fluids and hope for the best. And you can see here that over-resuscitation leads to extravascular fluid accumulation, leading to pulmonary edema, compartment syndrome, and prolonged mechanical ventilation time. It also increases the risk for heart failure and pneumonia. One of the big ones during the first 24 hours following burn injury is compartment syndrome and pulmonary edema. Of course, we can fend off some of the issues related to pulmonary edema because these patients are ultimately placed on mechanical ventilator, but compartment syndrome is very serious, mainly due to number one being that in severe burns your tissue is no longer compliant, and as your tissue expands, blood flow is lost, and this can lead to amputations. Abdominal compartment syndrome is also quite severe, and in very severe burns where the amount of fluids often is very excessive and it needs to be that excessive to maintain blood flow. This requires the burn surgeons, to do a decompressive laparotomy, and that in of itself also leads to other complications downstream. Well, how do we evaluate how well a patient is being resuscitated? And of course, this relies on intravascular monitoring. We have central venous pressure, or CVP. That's common. All burn patients, especially severe burn patients, will have a central line placed. We, of course, can measure serum creatinine, and we can also measure urine output. And, of course, we already do urine output because that's how we titrate the fluids during resuscitation. The problem is central venous pressure. It has a very poor relationship with blood volume. Many studies over the ages have shown that there's poor association with changes in CVP with fluid challenges, and CVP is greatly affected by mechanical ventilation due to the positive pressure inside the thoracic cavity. Serum creatinine is also not that great, albeit we use it all the time, and rises in creatinine occur after 50% or more damage. So by the time we see significant rises, the damage has already been done. And also we see that the creatinine half-life is also very slow, and it's been reported to be around 3.8 hours or so, possibly even more. And urine output, albeit it may sound easy and it's very convenient to use, it's not that great either. High urine output may not be representative of renal status during acute resuscitation. Especially in critical illness, we see that the glomerular filtration rate can be altered, yet urine output may remain the same. So this moves us into our current study, and this is done in collaboration between the University of California Davis Medical Center and Shriners Children's Hospital of Northern California. And this study uses both BNP and NGAL to be measured in these patients and to look at to help us identify predictive cutoffs for these biomarkers during acute resuscitation. The design is a prospective observational trial. We're looking at 30 adults and 90 children with 20% or more burns, and for this data set that I'm going to present to you today, we're going to focus on the adults. The method, of course, we're using point-of-care creatinine and BNP and NGAL measurements done every 4 hours for the first 40 hours post-admission. As a refresher, we can see that the point-of-care creatinine measurements are done using the Nova stat sensor creatinine point-of-care device. And our BNP and NGAL measurements are done using the triage meter from Alair. Some summary of results. We have patients identified as having AKI or no AKI, so no KI in the actual left-hand column and AKI in the right-hand column, and AKI is defined based on the rifle criteria. You can see that age, burn size, the actual fluid rate, mean arterial pressure or MAP, central venous pressure, and urine output are similar between the two patient groups, further underscoring how these methods of assessing renal function aren't that great, especially in the acute care setting. And we see that BNP and NGAL were actually significantly greater in the AKI group. In fact, you can see the NGAL, the average NGAL in the non-AKI group being 129 nanograms per ml versus 241 nanograms per ml. Creatinine was also significantly different in the two groups, with AKI patients having on average higher creatinine measurements, 1.37 versus 1.02 milligrams per deciliter. And in terms of the patients, we had 6 patients in the non-AKI group and 3 patients in the AKI group. The study is ongoing, so we of course will have more patients as we get closer to our endpoint for this adult setting. So looking at the mean serial measurements over time, so at the bottom are the actual sample collection points, 1, 2, 3, etc. And these, remember that these measurements are done every 4 hours, so 1 is times 0, 2 is effectively 4 hours, 3 is at 12 hours. And you can see that over the course of time, that the BNP does rise significantly above the in the AKI group versus the non-AKI group, and the measurements that were done to determine if the groups were significantly different from each other were based on repeated measures ANOVA. Moving on onto the next slide, you can see the mean NGAL measurements, again, every 4 hours, and you can see a clear, distinct separation between the two patient populations that have AKI versus no AKI. Again, the AKI patients are the solid black line, and the broken black line are the non-AKI patients. Creatinine is also distinct, and you can see that it actually rises after about 4 hours or so and continues to increase substantially in the AKI group over the course of time. Now, if we were to align the actual creatinine measurements and the NGAL measurements together, so that here the top is the NGAL, the bottom is the creatinine, and the green shaded area is the reference range for our two biomarkers, so 40 to 100 for NGAL and 0.44 to 1.27 for creatinine. And what's interesting to see is NGAL was already abnormal during the first sampling, whereas creatinine did not surpass its upper reference interval, so going to become abnormal until about 12 hours later. And this is pretty interesting, and can be simply explained by the fact that creatinine has a slower half-life. Remember, it takes 2 to 3 half-lives to really see something, and the half-life for NGAL has been reported most recently to be around 10 minutes, which makes it very useful for determining if patients are at risk for acute kidney injury, especially in the burn care setting. To conclude, we see that AKI, CKD, and CRS leads to high mortality and morbidity. Early prevention and detection are instrumental in improving outcomes, especially in high-risk populations. Common renal function tests rely on amperometry, as well as immunochemical methods. Traditional creatinine testing and urine output measurements may be inadequate, however, for predicting AKI, as you can see, since the physiology of critically ill patients can alter the actual presence of these biomarkers and give misleading results. NGAL and other biomarkers may be predictive of AKI, however, especially when coupled to other biomarkers such as BNP, and this leads to a great improvement in the clinical sensitivity of NGAL. BNP and NGAL may also have value for guiding acute resuscitation in critically ill, and in particular in burn patients.